Start.
Good evening. Can you all hear me?
Yes, sir.
Good evening, all the friends. First of all, welcome Dr. Naveen Malhotra sir, Honorary Secretary, National ISA, Dr. Yashveer R.A., Secretary Society of Anesthesia Haryana, Dr. Sunil Sethi, President Society of Anesthesia Haryana, and Dr. Vivek Saluja, President ISA Gurgaon City Branch, with very warm welcome to Dr. Sangeeta Khanna ma'am, Dr. Raki Maiwal, and we are still waiting, I think, Dr. Shweta Singh. I haven't seen her. And all the chairperson, Professors Chabra sir, Saluja sir, Professor Baljit Singh ji, Dr. Ved Popli, Dr. J.C. Druja, and Dr. Sunil Sethi. I think we can formally start our session. And the first topic is advanced hemodynamics monitoring in high-risk non-cardiac surgeries. The speaker is Dr. Shweta Singh, Director and Head, Department of Anesthesiology and Critical Care, Max Hospital, Delhi. The chairperson is Professor B. Chabra, who is advisor of ISA Haryana also, and Dr. Vivek Saluja, who is the President ISA Gurgaon City Branch. I think we can start our first topic now. Dr. Shweta Singh.
I'm audible to everybody. Good evening.
Good evening, sir.
Good evening, sir.
So please go ahead, sir. Chabra sir, please go ahead, sir.
The topic is on the hemodynamic monitoring and the question of the highly risk patient. Now the question of highly risk patient, I think that's what we have to define. What are this highly risk patient and what are the hemodynamic nowadays? Because we are using a non-invasive techniques nowadays, which is not being preferred. And non-invasive and the semi-invasive techniques are being used. Pulmonary catheter is no more in the picture now. So we'll listen to her. What are the high-risk patient and how this patient can be monitored and how the benefit of them hemodynamic monitoring can be done also. May I request Dr. Savita to speak? Along with I have got the he's a Saluja, who's a co-chairperson. Dr. Savita Singh, please.
Yes, sir. Just a minute. I'm just sharing my slides. Advanced.
Okay.
Good afternoon, everyone. Am I audible?
Yes.
Yes, madam. Very well audible.
So I've been asked to speak on advanced hemodynamic monitoring in high-risk non-cardiac surgeries. And so, as you were rightly saying, that pulmonary artery catheter, sir, is something which has gone out of vogue. So first I would like to talk about why we need a cardiac output monitoring at all. And I think that my slides are not changing.
And you have to make it full screen and just click on there and then you can move.
Fine. We know that cardiac output monitoring is important because whenever we are taking up a high-risk case, whether the patient being sick or the surgery being more extensive or advanced, we need to maintain the hemodynamics of the patient. And the cardiac output per se is dependent on a lot of factors, which would in turn maintain the hemodynamics of the patient. And if the hemodynamics are not maintained, like for example, if we have intraoperative hypotension, then it could result in various morbidities like acute kidney injury or myocardial injury. And it could result in patients having perioperative ischemic strokes. And even if the hypotension is to a small extent, transient hypotension for a short period of time, or a significant drop from the baseline more than 30%. So there is a lot of ambiguity on all of that. But we all know that maintaining of hemodynamics is of paramount importance. And when the patient is sick and the surgery is extensive, then we wouldn't know whether we are dealing with hypovolemia. Sometimes we would know because if there is hemorrhage, especially intraoperatively, and there's cardiac dysfunction or vasodilatation. So how should we address it? Will it be only fluids, or will it be inotropes or vasopressors? And then how much? And would it increase the cardiac dysfunction if we gave more fluid, if the patient is already having some amount of baseline cardiac dysfunction? If the patient is needing inotropes, and instead of doing that, if we load the patient with fluids, it could hamper the peripheral perfusion. If we need vasopressors, we could be doing something else. So if we're just relying on basic monitoring, we would see tachycardia as the first effect and maybe hypotension. But we have a plethora of other indices which could be used, like cardiac output, stroke, systemic vascular resistance, stroke volume variation, and these vary. So if the patient is in a state of SIRS or sepsis, we would have a drop in systemic vascular resistance. And if the patient is hypovolemic, there could be a drop in cardiac output associated with a rise in SVV and a rise in SPR. So these parameters would help us to make a good choice. And this was from a bulletin which was this was published in the bulletin of Royal College of Anesthesiology, where it said that within 5 years we would require cardiac output monitoring as one of the minimum monitoring devices for major surgery. And whether that, although has not been implemented so far as a basic criteria or a basic minimum monitoring, but yes, as the patient's age increases, as the comorbidities increase, as the if the surgery is extensive, or if there is expected that there's going to be a lot of blood loss or the anesthesia time is prolonged, then advanced monitoring should be considered. And it has been shown that early postoperative goal-directed therapy in major general surgery is associated with reduction in postoperative complications and duration of stay. And this comes with use of advanced hemodynamic monitoring. This could be discussed on the basis of how it happened, what all came, when and where, and how it stood the test of time. But I would go this way. I would like to describe which are the various cardiac output monitorings that we have access to, and how invasive they may be, or lesser invasive or non-invasive they are. And depending on our requirement, we could select, and depending on the setup and depending on a lot of things, we could take a call on which one we should be using in this particular patient. And each of them, if we have a basic understanding of what is the principle, what are the additional hemodynamic parameters it measures, whether they have been validated in clinical studies, what are the advantages and limitations, then it becomes easier to choose. So we all know that with Fick, who described the method of measuring cardiac output by calculating the total uptake or release of oxygen by the lungs, we start the era of cardiac output monitoring, or the thought was ushered in. And this went on with dye dilution using the Stewart equation, where it was told that if a certain known volume of indicator was added to the bloodstream, the concentration of the indicator as it passes the detector could be plotted as a curve of concentration over time. And using the Stewart-Hamilton equation for indicator dilution, it was possible to calculate the cardiac output. But this was a little tedious. And then came the thermodilution technique, where again using the Stewart-Hamilton algorithm, the change in temperature was seen instead of change in concentration of dye. The pulmonary artery catheter brought in a new era. It was considered the gold standard. It still is the gold standard, where we inject a specific amount of cold saline into the proximal port, and then the thermal variations of blood are measured. But although the two techniques were validated, the only problem is, as Sir rightly mentioned, that these are a little invasive. And so at that point in time, we were looking at cardiac output monitoring in major cardiac surgeries and critically ill patients in non-cardiac surgeries who had cardiac dysfunction. So pulmonary artery catheter was definitely the way to go. But the only disadvantage at that point in time, which we thought we could overcome, was whether we should use intermittent injections or we should have some device by which we could do a continuous cardiac output monitoring. So for that, we have this continuous cardiac output monitor. But even with a thermistor which was positioned in the RA and which could tell us the values continuously, although it gave us a lot of information, but the criticisms kept coming and problems kept emerging that there was critical arrhythmia associated with pulmonary artery catheter. I'm sorry, I'll just then there were other reports like entrapment of Swan-Ganz catheter, and ultimately, it was shown that unless if the patient is really sick, there is no clear evidence. You have to weigh the pros and cons, the benefit and the harm when you're using a device. And so perhaps it's not suitable to be used in all patients. So we have started exploring minimally invasive cardiac output monitoring. And for that, arterial pulse waveform analysis is the way forward. So although Otto Frank talked about it a century ago when he described the Wing-Kessel model, and he developed, the algorithm was developed a century later by Wessling, where he calculated the stroke volume possible by integrating the area under the systolic phase of the arterial waveform. And Erlanger suggested that cardiac output was proportional to the arterial pulse pressure in the beginning of the century based on the fact that the systolic part of the arterial pressure waveform is proportional to stroke volume. And this is measured from the end of ejection. This is measured from post-diastole, to the end of ejection. So a number of devices came which were using the arterial pulse waveform analysis. Some were calibrated, others which did not require calibration, like the flow track, and others which required intermittent calibration, like the PICO and the LIDCO. So PICO was the next step, and PICO was a device where they combined the pulse contour analysis, which is the area under the curve for a systolic, as I explained, the arterial waveform, along with the transpulmonary thermodilution cardiac output assessment. It is less invasive than the pulmonary artery catheter, no doubt, but it requires both a central venous and an arterial cannula. But various validation studies have really found good correlation of PICO with pulmonary artery catheter, not only during cardiac surgeries, but non-cardiac surgeries and in critically ill patients. So there is a beat-to-beat analysis of the stroke volume, and it combines the two technologies. And although they say that it has not helped and that there is no morbidity or mortality benefit in Europe and other places where the technology was floated in earlier, it is a technology which is being used for conducting liver transplants as well. The other thing is the lithium dilution. The LIDCO Plus is again based on the pulse power analysis along with, but this requires calibration. This requires injection of a set dose of lithium through a peripheral cannula. And then the concentration of lithium is measured by a sensor which is attached to an indwelling arterial cannula. So here again, you require a venous access and an arterial cannula. But unlike in a PICO, it does not require a central venous cannula necessarily. But this is again a technology which we've used. We've used it in our liver transplant patients, and you get a beautiful trend of the various values which all these monitors which provide us. In addition to just the beat-to-beat blood pressure and the heart rate, if you use these devices, you get a trend of all values, and even though they are not really validated for extreme hemodynamic situations and in pediatric age group, yet these devices are very useful. So if you have a place, if you have a patient or you have a setup where you can keep these devices and use them, then it is definitely useful to use them, which are based on arterial pulse waveform analysis. The flow track is another very good, useful device, a pulse contour device, which is based on the principle that there is a linear relationship between the pulse pressure and the stroke volume. They have come up with, I think, 3 algorithms. They first came up with one in 2000. And the present one also calculates with the help of arterial pressure waveform. 200 waveform points are taken and it analyzes, and at the end of every 20 seconds gives you a set of values. And this is what the screen looks like. It's very pictorial. And these values definitely help you in conducting a case where there are major hemodynamic disturbances in fluid shifts. The advantages, if you do a functional analysis, is that it gives you additional parameters like systemic vascular resistance, stroke volume variation. It has been validated, and advantages are that it is minimally invasive. It only requires an arterial cannula, and it is uncalibrated. Again, the accuracy of the latest, which is a 3rd generation algorithm of flow, is said to be controversial in septic conditions. But then even the pulmonary artery catheter has its own disadvantages. Even CVP as a static indicator has been told, but we continue to use them because there are places where the trends are beneficial. And this being a surgery, this being a device which only requires an arterial cannula, I would say that it can be kept in the patient for a pretty long period of time without thinking a lot. And you can use it if the patient is mechanically ventilated and is hemodynamically unstable, then it provides you with a whole lot of information. And it is very well seen that goal-directed intraoperative therapy, when based on these auto-calibrated arterial pressure waveform analysis, when they are used, it reduces hospital stay in high-risk surgical patients. This is what the screen of the volume view looks like. And this is one step ahead of the flow track. So volume view is a technique where there is intermittent calibration of their continuous pulse pressure analysis based cardiac output monitor. Here again, an arterial cannula is placed in a major vessel and it measures the change in blood temperature. And a software helps to plot a thermodilution curve of change of temperature over time. It helps us give us the same values as are given by a pico. So you have global end diastolic volume, intrathoracic blood volume, extravascular lung water, and pulmonary vascular permeability index from transpulmonary thermodilution. So it helps to combine both the technologies, pulse pressure analysis as well as transpulmonary thermodilution. And although again it says that they did not show interchangeability, yet these devices, if used in a patient who is very sick and is expected to have a turbulent post-operative course, then there is a huge amount of advantage. Coming to the less invasive, or let's say non-invasive, transthoracic Doppler is definitely useful. But well, if you decide to insert a probe or an esophageal probe for estimation of the cardiac output, then this is as good as it gets because it's non-invasive. But when we're putting it in a liver transplant patient, there is a lot of discussion on whether a patient with esophageal varices can receive an esophageal probe. But if there is adequate operator training, then this is a very useful tool for assessment of cardiac structures, the filling status, the cardiac contractility throughout an extensive surgery. And this has been validated and it shows good limits of agreement with a pulmonary artery catheter. It is useful, no doubt, in a patient as long as he is mechanically ventilated. This is what one of the probes would look like, and it is positioned in the at a level parallel to the descending thoracic aorta. And velocity time integral is calculated. The probe is placed in the esophagus. It is manipulated to achieve the optimal velocity time curve. The velocity time integral is calculated from the area under the curve, and the cardiac output is calculated from the product of the velocity time integral, heart rate, and cross-sectional area of the aorta by the software. Now, if there is time and if the chairpersons would permit me, I would go into the non-invasive cardiac output monitoring, sir. Should I go into the non-invasive cardiac output monitoring, sir? I can't hear you, sir. So going on to the non-invasive cardiac output monitoring, we have devices like the USCOM, which is the ultrasound cardiac output monitor. As shown in the picture, it involves placement of a probe at the suprasternal notch, and it measures. And then there are other devices like the PRAM, the pressure recording analytic method, which measures the area under the curve of arterial waveform analysis. This involves placing of electrodes. Then there is the NexFin, where an inflatable cuff is placed around the finger, and again it measures the arterial pressure waveform and the area under it. So it again uses an algorithm. So the more away we are going from invasiveness, the more, or should I put it, the more less invasive we become, it is definitely going to be not as accurate, but it has the advantage that you are being less invasive. Another device is the non-invasive monitor using pulse wave transit time. This is the NICO system, which is based on the fixed principle. Here, it uses a special patented rebreathing circuit, and it measures the carbon dioxide consumed. It has a disposable rebreathing loop, which is a proprietary product. It is attached to the ventilator circuit, and it measures the carbon dioxide consumed. This is transthoracic bioimpedance, where certain electrodes are put on the chest wall, and it helps to calculate the cardiac output in this manner. So I would like to conclude by saying that in this modern day era of medical practice, where we take up high risk patients and critically ill patients for surgery, cardiac output monitoring definitely helps, because it helps to guide the fluid therapy, the inotropic support, and as a result, it helps in improving the cardiac output and oxygen delivery. And in the process, it improves perioperative outcomes. So it is helpful to know the underlying principles of the various cardiac output monitoring devices available, understand their limitations, and hence choose the more effective and safer of them in our scenario, in our particular patient, as no single cardiac output monitoring device can meet all the requirements. There is definite proof that goal-directed therapy helps in improving outcomes, and cardiac output monitoring is a part of it. So since all devices are targeted to evaluate stroke volume either as an absolute value or as a relative change, depending on our setup, where the patient is, whether he is stable enough to be in the ward or in the ICU, whether he's in the emergency or in the OR, we can select which device we want to use based on the invasiveness. If the patient does not warrant the risk-benefit ratio, it does not weigh in favor of a pulmonary artery catheter, we could use something very non-invasive or minimally invasive. Thank you for your attention.
Thank you, Dr. Savita, for giving a very extensive talk. I think the question was that we have a high risk patient.
Yes, sir.
And then the monitoring of the hemodynamic monitoring. As we know that the high risk patients, we have to define, they are different method of defining, and the shoemaker given the first the list of that high risk patient, but it varies according to the setup also. But the question is that the high risk patient, they have got 50% cases, but they have 80% mortality. With this monitoring, extensive monitoring, does the output is better, and how much is better in your view?
If we're talking about critically ill patients, or if you're talking about high risk surgeries, so definitely if we as anesthesiologists can help a patient undergo a high risk surgery safely, then a cardiac output monitoring, even if it is invasive, its use would be justified. For example, in our setup where we are doing major abdominal surgeries and liver transplants, we use advanced cardiac monitoring routinely. So if depending on the requirement of the patient, if I say that I am talking about one surgery, for example, if I take a surgery, a hepatectomy, and if the patient is having some cardiac dysfunction, and I am doing an extended right hepatectomy, I would still wonder if I should use a pulmonary artery catheter in this patient, because I can manage with a less invasive cardiac output monitoring. For example, I could manage with a flow track. So maybe I would think which invasive, minimally invasive or least invasive cardiac output monitoring I would require for this patient with cardiac dysfunction, with maybe some amount of COPD and and a major surgery.
Even
So,
the non-cardiac patient also.
in a non-cardiac patient, I would not consider a pulmonary artery catheter at all if the patient is not undergoing a major surgery and there is no cardiac dysfunction. So for now, I would want to know whether any cardiac output monitoring at all is required, and if the patient is can be managed well with the help of a transthoracic Doppler rather than doing anything invasive, we would like to use that. But if we have a flow track, because that only requires, or a LIDCO, which requires only insertion of an arterial catheter, then it's a good device to have and use.
I think the minimum invasive will be better because the intra-arterial cannulation or the intravenous cannulation, along with the NICU and other techniques, can be helpful rather than going for the pulmonary artery catheter or the very invasive monitoring also. Thank you, Dr. Shweta. I think it's to open for the discussion. A question answer. Any question in the chat box? Any question we can answer? She can answer that also. If there's no question on the chat box, then I request I thank the speaker, and I thank on my behalf of my co-chairperson also. Thank you very much, and hand over the mic to the organizer. Thank you very much.
Hello.
I'll stop sharing my screen.
I thank the speaker and the organizers, and the hand over the mic to the organizer for the next session, please.
Thank you very much, Dr. Shweta, for a nice and very informative talk about the advanced hemodynamic monitoring in high-risk cases of non-cardiac surgery. Thank you very much, Professor Chabra and Dr. Saluja. With the permission of the House, we move on to the next topic. May I welcome Dr. Rakhi Mahiwal. She is an additional professor of hepatology in charge liver intensive care at ILBS Delhi, and she will be speaking on lung parameters in critical care management. The session will be chaired by Professor Baljeet Singh, and I'm the co-chairperson of this session. But I'll request Dr. Saluja to take part in place of me, because I have to move into the OT for oil. Thank you very much. Madam, please go ahead, Dr. Rakhi Mahiwal.
Thank you, Dr. Gupta, and a very good evening to all my colleagues. So I will be talking about lung assessment, particularly with respect to extravascular lung water assessment using the transpulmonary thermodilution technique. Okay, this is going to be the outline of my talk. I will take a case scenario, which we just managed in the ICU. We will talk a little bit about the understanding of extravascular lung water, followed by the technique, even though this has been nicely alluded to by my previous speaker, Dr. Shweta. And we'll go on to the clinical applications of this technique and how we use this in our clinical practice. So this is a case which we just managed. He was a young boy. He was 48 years, Mohit. And he had a patient, this was a patient of acute and chronic liver failure. And his last drink was around a month ago. And he had a great small esophageal varices. He came to us in a very sick state with a history of jaundice, which was there for a month, abdominal distension, decreased urine output, and altered sensorium. So he was received in the emergency in grade 4 hepatic encephalopathy, almost in severely hypertensive, requiring high doses of dual vasopressors. He also had a very poor and labored breathing. His skin showed some ecchymotic patches, and his chest had shown decreased air entry. His lactate at admission was 9. He had a high leukocyte count. His INR was 10, and his serum creatinine was 5.8, bilirubin of 19.5, and ammonia 197 at admission. He was a child C patient of MEL score of 55, SOFA was 20, and this is what we see very often in these patients, I will not go into the details of this, but this is bile cast nephropathy, which was seen in this patient, and he also had granular and renal tubular epithelial casts. The echo was normal for this patient. He received almost 1.5 liters of fluid in the emergency and before coming to the ICU and after being intubated. And the first thing which we do in such sick patients is to put a lung water, because we need to know his volume status. We need to know what is the lung parameters, and the extravascular lung water in this patient was 10.7 and PVPI was 3.2. The cardiac index and the cardiac output was normal. SVR was decreased mildly. The fibrinogen, the other lab parameters, and his COVID also, RT-PCR came as indeterminate. We also do biofire, and we found that this patient had E. coli and Klebsiella pneumonia dual infection, and they had resistance genes of NDM, CTX, and OXTROP48. His IL-6 and other inflammatory parameters were raised. His ECSTIM was deranged and showed fibrinolysis. So we'll go back to the case at the end of my talk. So I will be discussing first about what is actually extravascular lung water. It is all the liquid in the lung which is not in the vascular and the pleural space. So this comprises in majority, that is 65% of this is comprised as the intracellular water, and the remaining is in the interstitial compartment, the alveolar compartment, the lymph, which is seen in these patients. Now we also know the normal physiology. What happens in a normal lung is that the fluid in the lung is basically managed by the hydrostatic pressures, the oncotic pressure in the pulmonary interstitium. There is a tight alveolar capillary barrier which gets disrupted in increased hydrostatic pressure and decrease in oncotic pressure, which together will cause an increased alveolar leak by the compromise of this barrier, which is compensated in the initial phases by an increase in the lymphatic drainage. However, with advanced in these stages, where there is renal involvement and there is pulmonary vascular overload, so all these will compound the increase in the lung water in patients with ARDS. So under normal physiological conditions, the lung water is around 7 ml per kg, which is actually 500 ml and it may vary from 500 to 7 based on the different Caucasian races. And we know that the gold standard for the measurement will be a gravimetry, where we take out the wet and the dry weight, but this is not feasible in our clinical practice because this is only on the animals and in the autopsy series that we can do. So there comes the role of transpulmonary thermodilution techniques, which can tell us quite accurately about the status of the lung. We can also use other methods, and as I showed, that in a patient we can see the peripheries, we can look for anasarca, we can look for abdominal pressures, we can see ascites. In especially patients with liver disease, we can look at JVP and other signs of skin turgor. We can auscultate the chest and look for crepitations to understand the status of the lung. Obviously, a chest X-ray could be very easily available in most centers. CT scans can be done. A bedside ultrasound has become very popular. It can be done and can tell us accurately about the status of the lung water. However, we know that with the kind of ultrasound that we do, we are mapping only a small area of the lungs, so we are not objectively looking at the entire lung area. So these are the limitations of all these techniques, and there comes that whether we should be using transpulmonary thermodilution. And I'll not go into the details of this because it was nicely covered by the previous speaker. So basically what is done is that you place the catheters, the one in the venous system and the other is a thermistor capped in the arterial system. And subsequently, when you inject 15 to 20 ml of cold saline at less than 8-degree temperature, this passes through the pulmonary compartment, the right ventricle, the right heart into the pulmonary system, and then to the left heart, and then it is sensed by the thermistor. And here is where you use the different equations to calculate the intrathoracic thermal volume. You calculate the pulmonary thermal volume, from which you can derive the global end diastolic volume, which tells us about the total volume, which is there in all the chambers of the heart. And from there, you can derive the intrathoracic blood volume, which is 1.25 product of the global end diastolic volume. And finally, we get the lung water when we subtract this intrathoracic blood volume from the intrathoracic thermal volume. So this is a detailed calculations, but the machine and the software does it for us automatically. And these are the different indices which we get when we put a volume view flow track in our patients. And all these indices become very, very relevant in patients who are very critically ill, have hemodynamic collapse, where you want to have an assessment of how you should be giving fluids, what is the status of the lung, whether this patient has ARDS or not. So all these indices, so pulmonary vascular permeability index, the extravascular lung water, the global end-diastolic volume, which tells us about the preload of the heart, the cardiac contractility and the cardiac function measurements, the global ejection fraction, which can all be derived, are very, very useful. And obviously we can also look at the stroke volume variation in these patients to have an assessment of how we should be judiciously giving them fluids. Now, the other important part while we're looking at these measurements in our patients is that, and this was elegantly shown in this study wherein a large number of transpulmonary thermodilutions were measured in almost 3,691 patients, measurements which were done in 234 consecutive patients. So what they showed here is, this is the predicted body weight, and this is calculated by this equation, which is there for both males and females. This is the actual body weight, the ideal and the adjusted body weight. So what they showed here was that, especially in obese patients, so women and the patients who were obese, if you're using the actual body weight, you're actually underestimating and you're not calculating your lung water properly. So the best what is recommended is being that we should be taking the predicted body weight calculation for the measurements and for understanding this water. Now, coming to the clinical applications, the most important clinical application would be to identify and diagnose, prognosticate, and do a good therapeutic management of pulmonary edema and acute respiratory distress syndrome. And we all know, and I need not tell this audience, the limitations of the current definition. So we say it is an acute onset, and you need to have a radiographic assessment to say that the infiltrates are bilateral. But we know that radiology criteria are not sensitive, not specific, and the inter-observer variability is very poor when it comes to chest X-ray. So if we have an X-ray like this, there's almost 100% agreement with most of the experts. However, if you have an X-ray where there's just some consolidation, where there's some interstitial atelectasis, and the lung volumes are difficult to estimate, in this, the agreement drops down to 70%. If you see this X-ray, most of these, the X-ray, even though this patient had ARDS, the experts had missed on and they diagnosed it as pleural effusion. And the sensitivity and specificity further goes down if your patient is not showing the classical infiltrates. And therefore it becomes necessary that in such a clinical context, like in our patient also, the X-ray was unremarkable, but the patient has a very poor PF ratio. And we saw the next morning, all the lab reports were suggestive of a very difficult to treat pneumonia. So therefore there is a need for development of explicit and reproducible diagnostic criteria. And the diagnostic criteria which have been laid down with the American European Consensus Conference statements for ARDS are not reliable, and therefore there is a need for us to look at maybe a different, not just one criteria, but to go with different sets of in a clinical context, because we know that the other criteria, the third criteria that is required for the ARDS diagnosis is the PF ratios. And we also know that there are a lot of problems with the PF ratios because it is variable based on the lung compliance, the PEEP that we're giving to these patients. And again, it is not necessary that your patient may not be having a cardiac dysfunction. So even in a patient with a background cardiac disease, there may be ARDS. So it is not necessary that you need to rule out and see the lung assessment with the help of PF ratio. The ALI criteria also, so what the investigators or the experts had suggested that if you use the criteria for ARDS, almost majority of the patients would actually, with acute lung injury, may evolve into ARDS. So that's a continuum spectrum. However, there are different series, and it has been shown by a series by Lehr that only 2.3% of all acute lung injury patients which they classified developed ARDS, as against other series where 67 to 70% will progress to ARDS. So this was another nice study which was done on a subset of patients, which was around 30 patients, where they showed that with increases in the PF ratio are not reliable for ARDS. And if you keep increasing the FiO2, you will see that the PF ratios will change. And the PF ratio change was more markedly observed if the FiO2 was increased above 0.7. So this will influence our diagnostic criteria, and these are the limitations. And as I already mentioned, that because the ARDS diagnostic criteria also requires that we need to separate out the patient from cardiogenic, from non-cardiogenic pulmonary edema. So we need to have a more reliable parameter. So how does the volume view technique helps us is that it not only tells us about the edema in the lung or the lung water, but it also tells us about the capillary leak. And as I mentioned in my talk, that the alveolar capillary barrier disruption, which is supposed to be the hallmark, will be actually manifested in an increase in PVPI in these patients. So it was seen in this nicely done study that the patients who had acute lung injury and ARDS, they not only had a high lung water, but their PVPI was seen to be high, and in most of these patients, it was above 1.8. So if we take a combination of lung water and PVPI, we will see that if we use a combination, we can find out if both are low, we know that the patient is having a normal lung. If the lung water is increased and the PVPI is normal, we should be ruling out cardiogenic pulmonary edema. And as we go on to the higher spectrum, and if the lung water is also high and the patient has a high leak, either the patient has a mixed syndrome, or in patients in the extreme end will have a severe ARDS, and these need to be aggressively managed. Now, the lung water has also been shown to be an early marker and a sensitive marker. So we are using the acute lung injury scores of taking into PF ratio. But if you put a lung water, and if the patient has a high lung water, it is more likely that this patient has ARD, especially in the context of also having a high PEEP. And it was in this particular study, they showed that in patients who had high lung water and high PVPI, they more likely evolved into ARDS as against patients with acute lung injury who had low lung water and PVPI at the enrollment. Now, we know that the histology or the autopsy, which tells us about the diffuse alveolar damage, is supposedly the gold standard. And in this study of post-mortem lung measurements they did with the help of extravascular lung water and subsequently correlated with the histology of the lung. And they found that the lung water assessment was very, very accurate. And if the patient had a lung water of more than 9.8, this classified into the diagnosis of alveolar damage with a sensitivity and specificity above 80%, while if the lung water was above 14.6, the positive predictive value had gone up to 99%. So this is a very important way to diagnose on early a case of severe lung injury or ARDS. Prognostically also, it has been shown that in this particular study, when they looked at the enrollment lung water, they looked at the peak lung water and the average of the lung water of all the patients who were admitted with ARDS, and amongst all the other parameters, they found that the lung water increase with time was associated with increase in the death of these patients, and this was almost 7% increase with each unit increase in the lung water indices that was noted in this cohort. And therefore, lung water could be an early marker of not only, it can tell us about how your patient is responding, because correlation has also been seen with response to therapies. And if the patient remains a persistently elevated lung water, these patients more likely to die as compared to other patients where the lung water measurements are improving. Now, it's not that the lung water measurements, like any technique, has its own flaws and limitations. So the limitations of this technique is that it will overestimate in cases where there is with variations in PEEP and in patients who have lung resection, and it may underestimate lung water. So we have to look at these contexts, pulmonary vascular occlusion, where a PA catheter may also be very helpful, and we should be using a combination, maybe a heterogeneous lung injury syndrome, large pleural effusions, where it can give us an inaccurate assessment of extravascular lung water. Now, what about continuous veno-venous hemofiltration? And this particular study, which was done in 69 patients, the authors looked at different blood flow pump speeds, and patients were offered CVVH, and they looked at whether it was influencing the lung and the cardiac parameter indices as measured by the thermodilution technique, and they used the PICO system herein, and they showed that with different speeds of blood flow, which was used in this technique, they found that there was no change in the cardiac and the pulmonary indices. There was mild decrease, which was noted in the extravascular lung water index when the CRRT was turned off. However, this was not a significantly relevant parameter. Now, in non-ARDS also, it becomes very, very important for us because it's in patients who are critically ill, having a difficult septic shock. We can use the lung water indices to identify which patients. We can do a targeted management in altogether. So if the patient has low lung water and merits fluid expansion, we can give judicious fluids. However, if the lung water is high and the pulmonary wedge pressure is also high, we know that here we should be very, very cautious with the fluids, and rather we should consider early dialysis, or we should be considering diuresis in these patients if the renal functions are within normal limits. Now, it has been shown that people who go with a protocol-based management of sick patients who have lung water indices and based on the pulmonary artery occlusion pressure, and it was shown that if you do a protocol-based and an intensive management of these difficult to treat patients, you may be able to improve their overall outcomes. So in septic shock also, we can look at the permeability indices and the lung water. If the patient has lung water which is low but has high permeability, here again, we have to be very cautious because these are the patients who may leak out their fluid into the interstitial compartment. So if they don't, so both these indices will tell us a lot about how we should be hemodynamically assessing and managing these patients. And it has been shown in various series that there is improved survival in ARDS patients if we go with these protocol-based management and we do a judicious fluid management, especially in patients who come to us with acute lung injury or ARDS, and we will be able to reduce their overall mortality and also decrease the length of days spent in the ICU. So beyond ARDS, there are multiple series in general critically ill population in patients with severe sepsis and septic shock, where they have used the measurements of extravascular lung water using the actual or the predicted body weight. And in all these series, they have shown that these indices will tell us about the overall prognostication and will help us in guiding the appropriate fluid management and improve overall outcomes. In patients with necrotizing pancreatitis, again, this was an important study where they showed that volume depletion can easily be managed in these patients if we do a targeted management. If we're targeting the intrathoracic blood volume and managing the cardiac index, looking at all these parameters, intra-abdominal pressure, they proposed an algorithm suggesting that we should be using the intrathoracic blood volume index, monitor the lactate, see the extravascular lung water, the intra-abdominal pressures to decide on the appropriate fluid strategy, use of inotropes or vasopressors accordingly to ensure adequate tissue perfusion. And in their series, they showed that these patients who were at the end of 72 hours, we can see here that with the targeted fluid therapy and management, these patients had improved indices of cardiac and pulmonary function and therefore improved outcomes. Similar data has been shown in cardiac surgery patients, and overall outcome has been shown to improve even in this set of patients. And there are reports of snake and the scorpion envenomation from Tunisia, where again there is cardiac dysfunction and flow track guided measurements had shown to improve outcomes. So when to consider these hemodynamic monitoring systems, we should not be using them for all patients because of their cost, and obviously they're invasive. So yes, in a subset of patients where you're having a suspicion of ARDS, where you have a suspicion of cardiac dysfunction, where you're difficult to treat patients of pneumonia, where you have the refractory shock and you want to do a guided assessment of fluids, we can use those. And therefore, the lung water tells us about the safety parameter during fluid therapy, and this was proposed by this expert who is a pioneer in this field. So we go back to our case, and this is how the lung water indices with time with appropriate antibiotics. The CRRT was given to this patient early on in the disease course because we knew the lung water and the permeability was high. And after starting of CRRT, the patient had reduction in the vasopressor dosages. By day 5, we tapered the NORAD and we switched to this patient to terlipressin. The urine output had improved to 35 ml per hour. And we can see that the lung indices had all shown improvement. The lactate had improved. The PF ratios had improved. He was also given some albumin, looking and carefully watching the lung water while this patient had started to produce urine. These are the x-rays, and we see that the x-rays remain the same, and rather, even though the lung water had decreased, and we can see that the day 3 x-rays looking worse as compared to the day 1 x-ray. The INR was corrected based on the XGIM, and we found that the patient had only one issue, that he was having a progressive jaundice and liver failure. And to end it, the patient was given an option of a live donor liver transplant. After the resolution of all organ failures, they could not find a living donor. So subsequently, he was counseled for end of life care, and he succumbed just 2 days back in our ICU. So this is the data of last 2 to 3 months. We use FlowTrack for difficult to treat patients with pneumonia and septic shock in liver ICU. And we see that amongst all the parameters of FlowTrack, the PVPI is something which tells us, and after therapeutic intervention, we can see that the odds ratio of PVPI being high at the end of therapeutic intervention is a very important predictor of overall poor outcome of these patients. Thank you. So I would like to summarize in the end that even a small amount of extravascular lung water in excess can cause pulmonary edema. Gravimetric measurements are gold standard, but the thermodilution is a very good technique, and it's highly correlated with the gravimetric measurements. The importance of extravascular lung water is best established for ARDS. It can help in diagnosis, prognostication, and also can be a very good guide to the therapy. And extravascular lung water can also help us in fluid management in difficult to treat scenarios of hemodynamic collapse and cardiac dysfunction. Thank you.
Well, thank you, Dr. Akhi, for a very thought-provoking talk on vascular lung water. There is one question. Let's take up that first in the chat box, and the person has asked, what is the cost of the equipment? Although, this is probably not the forum where we need to discuss, but since that gentleman has asked a question, so can you please tell us the cost of the equipment?
Yeah, so one-time placement of when we use the volume view technique, it's costing around 27,000 to the patient in our ICU. And if you use the FlowTrack routine, then it's around 20,000 without the volume view.
That is what comes to the patient. You see, he was asking, what is the cost of the equipment that you use?
Equipment, we have to buy the monitors for one time. Cost of equipment is, monitors are costly, 1 crore or so. I think so one monitor costs around 1 crore of rupees.
Okay. Yeah, okay. So I hope that satisfies the gentleman. Now, since there is no more question in the chat box, so maybe 1 or 2 questions I have for you. One is that how can we differentiate cardiac from lung disorders with this parameter? Can we, first of all? And if we can, how accurately can we diagnose based on this parameter?
So obviously, this they tell us about the cardiac function. So the machine is telling us about the cardiac function indices. We get the cardiac output, we get the cardiac index, we get the all the other parameters related to the lung. When we talked about extravascular lung water and the pulmonary vascular permeability, but I would not say that we should go by this. A good cardiac echo anything cannot replace a good cardiac echo. So this should always be done. If you're suspecting especially a right heart dysfunction, this is not reliable, and it can actually be fallacious. So we should always do a cardiac echo for our patients before we go on to this technique. But yes, while we have ruled out a significant cardiac problem and we want to see the cardiac performance on vasopressors, whether we want to change, we want to add inotropes, we want to improve the SVR in a hyperdynamic circulatory state, then this machine is quite good to see the dynamic changes.
Should I take the statement as something that just like this parameter for lung pathologies is equivalent to kind of an echo that you have for cardiac disorders? Or you would place it differently?
Yeah, it could be. We can say that it gives us a very good assessment of the lung. Definitely, sir.
And how about its accuracy in determining the role of fluid therapy in a patient with lung disorder? you have mentioned very clearly. I think you made it very clear, but still I would like to know how accurate is its role with regard to the fluid management.
Sir, we have seen in our own experience, even though the literature says that it is very accurate, with good accuracy, the accuracy has been reported about 80 to 90% in different studies. But we do see that even with high lung water, if the PVPI is normal, and we see IVC assessment also, we do a lung ultrasound. So we see at least 2 to 3 parameters for us to make sure that the patient, like if you want to give fluids, even with a high lung water, I can give, because we see that in early phase of acute lung injury also, sometimes you see a high lung water, and maybe other conditions like a high PEEP or other things which can influence the lung water assessment, how we have done it, whether we are taking a 3 average reading. So there are a lot of things. So it's not that we should be going just one parameter. If we have other signs to suggest, then even if the PVPI is okay, then I would definitely, if my all other signs, the clinical signs and my IVC is suggestive, I may give fluids. And especially in cirrhotics, it is very, they are hypovolemic, so we do give fluids, IV albumin in these patients.
Thank you so
But
much
yes,
for
we
that.
do keep a watch on the lung water indices.
Yeah. There's another, I think, answer to the question of the cost of equipment. Somebody has, Dr. Praveen Tiwari. He says that the monitor cost starts somewhere from 25 lakhs and goes up to 35 lakhs depending on the modules opted. Well, anyhow, that's another information. Now, I have one more question. I won't, bother you with many of them. Well, that's all right. This kind of equipment in a high-end institute like yours, ILBS, is fine. A research-oriented institute, and of course, the last word I would say in the management of liver disorders, and of course, intensive care. Now, if an institute doesn't have, if a hospital doesn't have this measurement facility, what next can be available, which can give us the same kind of information that you would get with measurement of this, parameter?
There was a very nice study which I was reading, and it was from actually an Indian center. And what they looked at was the lung ultrasound. Lung ultrasounds, and we find a correlation with the lung ultrasound and X-ray, and maybe one-time CT scan, and daily assessment with IVC collapsibility. And so in our ICU, supposing we have 25 patients, so we're not using this for all 25 patients. We use it in 3 to 4 sick patients. The rest of the other patients we manage using a combination of lung ultrasound and chest X-ray and IVC measurements. So this is what, and the pulse pressure variation if the patient is on mechanical ventilation. So the monitors can tell us about the pulse pressure variations. Those things we usually consider for all other patients. But yes, if we are having a very sick patient with pneumonia, with shock, with kidney injury, we would like to go full on with a good measurement. So.
I fully agree with you. Thank you so much, Dr. Aki. I would like to have Dr. Vineet Gupta in case he has something to say. Dr. Vineet Gupta, are you there, please? Dr. Vineet?
Dr. Vineet has gone into the OT right now.
Okay. So since, I don't have any other questions in the chat box, and I think I would like to thank Dr. Aki Maiwal for an excellent talk, provided a lot of insights into this parameter. Although it may not be available in all the hospitals, but I think the information is very important for us, all the anesthesiologists and for intensive care physicians. Thank you so much, Raki, once again. And I would also like to, take this opportunity to thank the organizers for giving me the opportunity to share this time with you, particularly Dr. Sunil Sethi, and of course, Dr. Veer Malhotra and Dr. Saluja. Thank you so much, and I hand over the mic back to the organizers. Thank you so much once again.
But it's always an honor to have you with us, sir, Dr. Baljeet Singh, sir. It's really so nice.
Thank you.
And Dr. Thabra is also here. So it's really
Guru. Sat Sat Pranam.
Right. So thank you, Dr. Raki, for a very nice talk on the importance of extrapulmonary lung water. I would now like to invite Dr. Sangeeta Khanna, who is the Director of Anesthesia at Vedanta Hospital, for her talk on intraoperative hypotension and artificial intelligence. Okay, your chairpersons for this session will be Dr. Ved Popli, who is the President ISA Faridabad City Branch, Dr. JC Dureja, who is the Director at KCGMC Karnal, and Dr. Sunil Sethi, who is the President Society of Anesthetists of Haryana Anesthesia. So Dr. Sangeeta Khanna, please.
Hello. Hello.
Hello.
Hello.
You're audible, Dr. Sethi.
Yes. Before we start the next talk, I will thank from my core of the heart to Dr. Bilbir Chabra sir, who has consented for the chairperson of this session. I am humbly thankful to Dr. Bilbir Singh and Dr. JC Dureja for honoring us to be with us on this webinar. And definitely Dr. Naveen Malhotra, National Secretary ISA, who is doing so much of hard work and making these things happen. And thankful to the esteemed chairpersons, Dr. Rakhi, Dr. Shweta Singh, and Dr. Sangeeta Khanna for their excellent talks. And notwithstanding in between you, I request Dr. Sangeeta Khanna to proceed with the
Thank you, Dr. Sethi, for that opportunity to speak in this forum. And after those excellent presentations, I would like to talk on a very simple and basic topic, that is intraoperative hypotension and the role of artificial intelligence in anesthesia. So for long, I think, over the last one decade, if we see, there is a lot of work which is being done on hypotension. And why is it important for us to look into this one basic parameter, that is the blood pressure under anesthesia? And if we see that, when we are awake, our blood pressure, is maintained within a particular range. But once we anesthetize that patient, there is a lot of fluctuations in blood pressure. It may vary, the pressure may drop, it may increase. And this is all because of the altered autoregulation that occurs because of loss of the compensatory physiological mechanisms, because of the drugs that we use, maybe because of surgical manipulations. So as an anesthetist, it is extremely important for us to maintain that blood pressure in one particular range. And why do we think it is important for us to do so? Because of the adverse outcomes that which occur in these patients in the post-operative period. And do we have evidence to support that, yes, these are associated with adverse outcomes? Oh, yes, definitely. And I will go through quite a few of these articles which tell us that intraoperative hypotension is associated with adverse outcomes. This was one of the original articles which was published in the British Journal of Anesthesia in 2018. And it is a review article where, they did a systematic search in PubMed and Embase and picked up 42 articles. And what they found was that, if we had a drop in a mean arterial pressure to less than 80 for more than 10 minutes, that itself was also responsible for adverse outcomes, organ failures like cardiac injury or renal injury or brain injury. And if we look at this, I was also quite surprised at seeing it, that the mean arterial pressure, which they are saying is 80 millimeters of mercury. Most of the times in the OT, what we are maintaining something between 60 to 70. We never aim at a pressure of 80. And then they calculated as, even a short duration as less as, maybe 1 to 5 minutes, less than 55 millimeters of mercury was associated with much greater adverse outcomes. And they said that we have to be extremely vigilant when we are looking at this blood pressure, and even short durations of drop in the blood pressure intraoperatively will lead to post-operative very poor outcomes. This was substantiated by another article which was published by Salmasi et al., who did a retrospective analysis of more than 55,000 patients, because the previous study was a review article of a lot of studies. So, there were different definitions of blood pressure which were used. Some authors had used systolic blood pressure, some had used mean, some had used the change from the baseline. And also the definition of, the outcome, whether how the outcome was measured, like the kidney injury and the myocardial injury, whether the changes in ECG were used or just changes in the tropi or levels were used. So because of that ambiguity, what they did was, okay, let us just look at the mean arterial pressure and look at, a change, whether there is any difference, when we look at the mean, or whether we look at a change from the reference baseline, like 20% above and below the baseline. Is there any difference between the two? And what they observed was that whether you use the mean arterial pressure, or whether you use a change on a relative, that is a change in the threshold of 20%, both of them, irrespective, are responsible if there is a drop in pressure below 20% or a mean arterial pressure less than 65. Both of them are associated with myocardial as well as kidney injury. And another thing that they concluded was that, that it is not related to a preoperative blood pressure. Whatever the preoperative blood pressure may be, we need to ensure that our mean arterial pressures and remain above 65 mmHg at all costs. And this was again substantiated with a very big study of more than 33,000 patients by Walsh et al. What they did was, they said, okay, just let us look at a map of less than 55 mmHg. But what they said was, let us look at the time zones. Like, when the patient from 1 to 5 minutes at that pressure, then 1 minute, 1 to 5 minutes, 5 to 10 minutes, 10 to 20 minutes, and more than 20 minutes. And at each level, they found as the duration of time elapsed in the hypotensive phase, the odd ratio of developing either a kidney injury or myocardial injury kept on increasing. You see from 1.18 to 1.3 to 1.5. And similarly, myocardial injury also increased similarly from 1.19 to 1.79 and 1.82. So they also concluded that short durations of an intraoperative map of less than 55 millimeters of mercury is associated with acute kidney injury and myocardial injury, and hence we must ensure that we do not have even a short duration of hypotension in the intraoperative period. So this graph clearly shows us the relation between the increase in kidney injury and myocardial injury as our map goes below 50, 40 and goes down to 30. So when there was so much of work already going on the intraoperative hypotension leading to adverse cardiac adverse outcomes, whether it was cardiac or kidney, because these are the two main organs which are usually studied. We do not really look into mild cognitive dysfunction and all those things. So there was this group from France, Foutier et al. What they did was, they just picked up high risk patients who are ASA grade 3 and who were prone to developing some kind of organ dysfunction and undergoing major abdominal surgery, which was under general anesthesia and would last for more than 2 hours. And they divided their group into their patients into 2 groups. In one group, they used their standard technique, that is, they would treat the SBP less than 80, or if it was less than a baseline, a drop from of more than 40% from the baseline. And in the other group, what they did was they had an individualized management strategy where they aimed at keeping the systolic blood pressure within 10% of the reference value using norepi. And what they found and what they studied was the primary outcome was again, composite organ injury or organ dysfunction in any one of the organ systems involved. And secondary outcomes included the length of stay in the ICU, the hospital, and an all-cause mortality at 30 days. And what they observed in this group was in the individualized treatment group, the primary outcome event occurred in 30% of patients compared to 51% patients under standard care. And the secondary outcomes occurred in 46% of the patients as compared to 63% of the patients in the standard care. So if we look overall, the rate of complications or post-op adverse outcomes is quite high. Maybe because the group that they selected was also high risk, like, an ASA grade 3 patient and who were already prone to develop some kind of injury in the post-op. But if we compare the two groups also, we see that those who had standard care had much more complications as compared to those who received an individualized treatment. So as they say that one size fits all, I think that is not what we should have when we are anesthetizing our patients. I think we need to select, we should not just go by an arbitrary thing like, okay, my aim is just to keep a MAP below 55, or, my aim is just that the reference value goes less than 10% or 20%. I think we need to select our patients, we should see what kind of surgery he is undergoing, what is it that we think that, complications he may develop in the post-op, and then decide what kind of strategy we want to use, rather than just trying to aim at a number which may really not be beneficial for that patient. And to take this further, we had there was Stapelfeld et al. What they did was, they developed a new scoring system which could, gives us an idea or predict an odds ratio of patients who would develop some kind of post-operative complications and at what level they would develop. This they called was the St. Louis University, or the SLUS score. What they did was this, they studied the electronic data from more than 1 lakh patients, and they studied it across 31 thresholds of pressures between 45 to 75 millimeters of mercury. And at each threshold, they measured the time that those patients had spent at that map value, and this they called was the hypotensive exposure time. When they had this cumulative time score, they studied it on a developmental cohort, and they said that, okay, now when we see the amount of time each patient is spending at this hypotensive exposure, what is the odds of them developing some kind of post-op complication, which they called was the SMART exposure limits. And when they studied that and projected on a prospective cohort, they developed this score, and they found was that anybody who had a score of more than 0, there was a 5% increase in the odds of developing a post-op complication, and this kept on increasing as the score increased by even 1 unit. And here we can clearly see in the red line that as the amount of time spent below 75 increases, the mortality increases. And another observation which they made was that the hypertensive patients required to spend lesser time, even shorter durations of time spent in the area between 75 to 45, had a greater chance of developing a post-op complication. And here, as we can clearly see, that as the SLUS score kept on increasing, the 30-day mortality also increases, the incidence of developing septic shock or some kind of organ space infection or renal failure, everything keeps on increasing. So this was a very innovative score which they developed. And if we could put these, if we could classify our patients and give them a score, we could be able to project that, yes, this patient is prone or may develop some kind of post-operative complication, and we need to take care of them. So as we see that we have a lot of literature which is supporting us, and a lot of evidence which tells us that, blood pressure is the most important parameter which we need to keep within limits to ensure that we can give a good quality outcome to most of our anesthetized patients. We need to think as how is it that we can do to ensure that it remains in that range. So far, what we have been doing is we have been reactive. That is, when we see that the blood pressure has dropped, we look at it, then we try to analyze, okay, what are the causes, what may be the reason for that drop, and then we would want to think about treating it. Then what happened is, over the past few years, as speakers discussed, we have advanced hemodynamic monitoring tools which came up, which are, we can say, are the proactive ones. That is, they tell us, okay, there is a stroke volume variation that is occurring, or there is a increase in the elastance or something. So, okay, this patient needs some action needs to be taken, and so we started giving them fluid or inotropes depending on the condition, and we try to prevent the hypotension from occurring. But now is the time to be predictive. Predictive is that we have to, if in advance we can ensure that this, come to know that, okay, this patient is going to develop hypotension, then we will be acting much before the compensatory or physiological mechanisms in the body have started, and prevent them going into a vicious cycle and developing any complications in the post-operative period. So the trend of today is to be predictive rather than to be reactive or proactive. And this has been made possible with the help of artificial intelligence. Artificial intelligence, there are various kinds, but what we are using is called machine learning. Machine learning is nothing but a subset of artificial intelligence, which learns from the data that has been fed into it and improves with experience, and it does not require any explicit or outside programming. And within the machine learning also, there is something which is known as supervised learning, in which, it is the data which gets fed in is keeps changing with inputs that are put in. And so each generation of the algorithm or the tool that comes up is much better than the previous one. And we are already using this in anesthesia for our decision making. Like, we have the BIS, the QCon, the use of TIVA pumps, then we have the QNOX, the advanced hemodynamic monitorings, the neuromuscular monitor. So these are all subsets of an artificial intelligence and machine learning, which we are already using. So can we predict this hypotension with the help of artificial intelligence and machine learning? Yes, we can definitely do that. And this work had started already in 2010 by a group of workers, but it did not pick up much because this was a study which they did in ICU patients. And they said that, yes, definitely there is a pattern which is there. And if we are able to pick up this pattern before hypotension sets in, we will be able to have an algorithm which will predict hypotension. And this was eventually possible with the work by Firas Khatib. What he did was he collected data, retrospective data of around 1,300 patients. He studied the arterial waveforms. And from there, he studied, there were around 3,000 peculiar artifacts which were picked up, out of which 51 was what the machine considered as important enough. And those 51 parameters were put into the algorithm, from which more than 26 lakhs different combination of waveforms emerged. And this, when was put into with the help of machine learning and artificial intelligence, was able to predict a drop in blood pressure less than 65 millimeters for 1 minute. And this, the sensitivity and specificity of this algorithm was around 87 to 88%. And this is what he called was the hypotension prediction index. And this is Firas Khatib who developed this algorithm. So what we are actually doing is, we know in the body, if the hypotension has to occur, so the event has already occurred, the physiological mechanisms come into play and prevent it from occurring. And it is only when we see the drop in blood pressure, then we start acting. So if we actually look on the time frame, it is around 15, 20, or maybe at times 25 to 30 minutes before we have started acting on an event which occurred at least around 30 to 35 minutes ago. So we do not want to do that. We want to be more proactive and try and either just prevent that event from happening, so that the patient does not go into the spiral of developing hypotension and some kind of post-op complication. So the landmark study by Khatib et al. Showed the potential of artificial intelligence for analyzing and predicting cardiovascular hemodynamics, and he developed this algorithm which he called the hypotension prediction index. And if we look at it, how it is done is, if we look at the arterial waveform, it consists of a systolic phase, a diastolic phase, a systolic rise phase, a systolic decay phase, and overall decay phase. In this, they identified around 3,000 features, from which 51 were considered important, and around 26 lakhs combination waveform features were formed, which were put into the machine learning and model training. And this was able to give us this tool or this algorithm, which we called as the HPI. And this is actually a record of one of the patients. If we see that the time when actually hypotension occurs, and if we look at the HPI, it was 15 minutes before that, it was already at a value of around 80 to 85, which was telling us that, okay, the hypotension is about to occur, which it actually did 15 minutes later. The limitations of this was that, it is not able, to predict if the hypotension will occur after induction. Also, it has not been validated for clinical interventions like laparoscopy or liver manipulation or vascular clamping and decamping. And the algorithm was developed using a cohort of both surgical and ICU patients, although it was validated only in surgical patients. And there is a gray zone because, between 65 to 75 millimeters of mercury, because less than 65 was considered as hypotension and more than 75 is considered as normotensive. So that gray zone still exists. So, it is not able to predict if the pressures are going to be between 65 to 75 millimeters of mercury. And as we see, as the HPI increases from, as it closes to the number increases, like 75, 85, 80, 85, the percentage of hypotension developing also keeps on increasing, and the time for it keeps on decreasing. So higher the HPI, the higher is the event rate, and shorter is the time for that event to occur. This is how it actually happens, that that there is a drop in pressure. That is the time, at least it will take us 20, 25, 15, 20 minutes for us to act on it, to prepare the drug and start. But if you look at the HPI, you see that around 11 o'clock the HPI was saying that the pressure is going to drop, and by the time we actually acted upon it, it was almost 11:45. So that, I think, is a normal way in which most of us would look at the blood pressure, think about what to, whether we need to act on it or not act to it, and then finally do something about it. And so Sogel et al. Had a review article on this, on hypotension prediction index, and it is basically a unitless number ranging from 0 to 100. Higher the number, higher is the probability, and shorter is the time for it to develop. And for each data set, period of hypotension, map of less than 65 for 1 minute, and non-hypotension more than 75 was noted for the training set. And this value is calculated every 20 seconds and displayed on the monitor. It represents the probability that the patient will develop hypotension, which is defined as a map of less than 65 for at least 1 minute. This is made possible with the help of a sensor, which is called an Acumen IQ sensor. This is how it looks on the monitor. You have a figure that will come, which tells you that this is the parameter. And if this exceeds 85, an audible alarm will sound. If it exceeds the limit twice, then a secondary screen will come up. This secondary screen will show other hemodynamic variables like the preload, the afterload, and the contractility. That is, we can see the SVV, the dynamic elastance, and the dP by dt ratio. And it will also prompt us as to to give an idea as what the cause is for this hypotension, and what are the possible measures that we need to treat this. So this is the secondary information that comes on the screen. This commercially became available along with EV 2000, as well as with the Hemosphere Edwards Life Sciences platform. It was approved by FDA in 2018. It is yet to launch in India. There have been studies already been done to check the sensitivity and specificity, and whether it is a useful tool or not. And Ranusi et al. Did this study on a small group of 23 patients, and they kept a cutoff value of HPI at 56. But at that level, its predictive value was only 9.8% with a specificity of 83%. And what they concluded was that if the HPI value was increased to 85, the negative predictive value was 97. And it was a good warning signal for the clinician. And as the value kept on increasing to more than 98, the probability of having an hypotensive event after 5 to 7 minutes was 64%, which was generally high enough to trigger adequate intervention, potentially to prevent this event. So Kandale et al. Did a study if it was able to predict post-induction hypotension. And what they did was that, yes, this algorithm demonstrates the feasibility of the use of machine learning models to predict analytics in the field of anesthesiology. Greenberg et al. Did a HYPE randomized trial in which they divided their patients, 23 patients, in 2 groups. And what they did was, they calculated, one was the standard group where they did the standard monitoring. The second group was where they used the HPI. And they measured the time weighted average of hypotension. That is the amount of time a patient spent below 65 millimeters of mercury into the time spent over there, divided by the total duration in minutes. This is what we call as the time weighted average of hypotension. And I think this is an extremely important thing which we should look into, rather than just looking at the number, because it is the duration also spent below the map which is as equally important as compared to the map. And what they observed was that this is the algorithm which they used to treat when the patient developed hypotension. And what they observed was that the time weighted average of hypotension in the intervention group was just 0.1 as compared to 0.44 in the control group. And the amount of time also the patient spent below the hypotensive threshold was also much lower, 8 minutes in the intervention group as compared to 32 minutes in the control group. Then Schneck et al. Used this protocol for their patients who were undergoing primary total hip arthroplasty, in which they used divided it into 3 groups. In one group, they used the HPI. The second group was the standard care, which they were using 25 patients in each. And this they compared to an historic control group, historic control which they had been doing over the year, previous few years without any advanced hemodynamic monitoring. And again, they said that the HPI algorithm combined with a protocolized treatment was able to reduce the incidence and number of hypotensive events in patients undergoing primary hip arthroplasty. Davis et al. Studied it in 200 and more than 250 patients. It was again a 2-center retrospective analysis. And what they said was that, the specificity and the sensitivity of HPI was in the range of 85% at 5 minutes, 81% at 15 minutes, and around 80% at 15 minutes before predicting an hypotensive event. So after we know that, okay, we have a tool that is available to predict hypotension, do we really need to use it, or it is just something that is there and it is not really going to be beneficial? So all this work has basically come to be known, what is known as the butterfly effect. The butterfly effect is, what is used in meteorology, which was studied, like, the particular way in which a butterfly flaps is able to predict a tornado, which is going to happen 2 weeks later. Now, this change is so subtle that it is not going to be recognized by the human eye, and we are not going to put any significance into it so as to say that it is going to predict such a major catastrophe. So similarly, the changes which are happening in the hemodynamics, in the arterial waveform, they are so subtle and they are so small that they cannot be visible to the human eye, and we cannot pick it up also. But then they are significant enough to predict that yes, a major change is going to happen in the hemodynamics. And hence, it is important for us to, pick up these small changes in hemodynamics, which a human eye cannot pick up, but with the help of machine learning and these algorithms and tools, they can be picked up at a much earlier stage, and they are able to predict an outcome, or rather we are able to prevent an outcome which is otherwise going to be detrimental to the patient. So in overall, before I conclude, I would just like to say that intraoperative hypotension is common. It has far-reaching adverse consequences. Prolonged period of hypotension is as bad as a short period of hypotension. Till now, we were following a reactive or rather a proactive management of IOH, but it is time that we have a predictive or a preventive management of IOH with the use of tools like HPI. And in this, I would like to emphasize on the word tools. So this is just a tool. It cannot remove the human interface from there. We as anesthetists have to be vigilant and have to use this tool properly so we are able to give a very good outcome to our patient. We cannot depend on this tool and depend on this number and just treat it blindly. So the important is that we will as anesthetists keep getting a lot of tools to play around with, but we do not have to be fooled by these tools. We have to use them judiciously so that we can give good outcomes to our patients. Thank you.
Thank you, Dr. Sangeeta, for a nice presentation. And this is very core to the anesthesiologist. Day in and the blood pressure remains the cornerstone of any monitoring. And especially at the induction time, we don't know which patient is going to have a blood pressure drop, though in spite of all the precautions being taken. My concern here is whether machine or not machine, this blood pressure, as you said, we learned today, even for a minute drop of your predictive value, less than 65 MAP, has a catastrophic effect in the long time. But have all this been established, and all blame goes to only blood pressure drop or something other multiple issue involved the patient caused the injury, as you said, kidney injury or this myocardial injury or brain injury, number one. Secondly, even the machine is not with us. if this knowledge share goes in public, should we be charting honestly, or we should just not chart properly? Because if we just chart 3, 4, 5 minutes, the patient had a blood pressure drop, and then this can be used against anesthetist legally. Is there any legal angle to that in the long time to come, as the charting goes in a record?
So, sir, the answer to the first is that most of the studies which have are retrospective analysis. Obviously, we cannot have a prospective, study on all this, and they have linked. There may be other parameters also, but definitely what they have said is that the blood pressure is the one of the most important parameters which may result. It is not like a direct causation between drop in blood pressure and an organ injury, but they have all said that it is one of the most important parameters which is associated with a post operative adverse outcome, whether it is kidney injury or myocardial injury, because these are retrospective cohorts, and because they have the access to their electronic database systems of more than 30,000 or 55,000 patients. So they are able to have that, develop that kind of correlation and say that okay, that the blood pressure is the one which is actually a very important thing which can lead to adverse post-operative outcomes. So that is what has been established in most of these analysis and review articles that have been published. And as far as going to, I think whether we have to chart it and the medical legal complications associated, I think we need to be vigilant enough, because I mean, I think the moment we notice hypotension, also we definitely act on it. It's not that we will be sitting on it and not doing anything about it. So I don't think that there should be any question of whether we should be charting, because if there is a drop in pressure, we always use whether we give a bolus of ephedrine or mefentin or phenylephrine, whatever is there, or increase the fluids. But we definitely ensure that we have looked into it and acted upon it if it is required to.
Thank you, Dr. Sangeeta. Now over to Dr. Dureja, please.
Thank you, Dr. Sangeeta, for a very informative talk on a very common problem which is usually faced by the anesthesiologists in the day-to-day practice, and also on artificial intelligence. And you rightly pointed out that its sensitivity specificity is around 85 to 87%. And Dr. Chavda also replied to a query which was, it predicts all the transplant 5 minutes before the actually happens in the hypotension. And I want to say that since it requires this invasive pressure monitoring, as well as this very costly equipment is required, so it cannot be recommended right this time for routine daily surgeries. It will be useful in the coming time for the especially cardiac surgeries or the neurosurgery or the joint replacement. And it also does not provide a continuous learning process, which is usually seen in the other thing. And secondly, even if there is a sensitive specificity is 85 to 87%, and it predicts even in the lesson around 5 minutes earlier the actual time of the hypertension to occur, but it cannot replace the care which is provided by the anesthesiologist.
Yes, sir. I would totally agree with you that it cannot replace the care provided by the anesthetist, and it is not a tool for all patients. Definitely, it is just for our high risk. Patients who are undergoing really major surgery, patients who are very sick, and who are definitely going to have some kind of adverse post-op event, or we know that these are high-risk patients who already have some kind of pre-op kidney injury or coronary artery disease, and they can have a chance of developing some kind of or previous history of stroke. So these patients whom we know definitely who will have some kind of may develop some kind of post-op complication, I think it is basically to keep a watch and to just make us more vigilant in these sicker group of patients, I would say, so that we can give them a better outcome that we would otherwise not be able to provide. And it definitely we cannot remove the human interface from any tool, that is for sure.
One thing more, Dr. Sangeeta, does it predict something? What is the cause? Whether it is preload, afterload, or the contractility problem? Does it give some fair idea about that?
Yes, sir. Yes, sir. There is a screen which will the stroke volume variation, the dynamic elastance, and even the DPDTs, and stroke volume. All these measurements also come, and the screen will definitely prompt us as to tell us whether it is the preload, the afterload, or the contractility which is being involved.
And what about this? If the hypotension is secondary to the surgical manipulations or something, right?
Yeah, that is the limitation. It has not been studied for those. Maybe it has still not been validated in all those kind of laparoscopy induced drop in hypotension is there, or liver manipulation has caused it, or if there has been clamping and when you have unclamped a major vessel. So it has not been studied for any of the surgical manipulations.
So in nutshell, supervised machine learning will be the key next time to come.
Yes, sir.
Thank you, ma'am. Thank you very much.
And Dr. Sangeeta, what is any study which tells about there is change in the morbidity or mortality if you use the artificial intelligence?
So I did not get it.
Any study which tells about there is a decrease in the morbidity or mortality if we compare it with the standard method of treatment, and where the artificial intelligence is not
There have been a few studies which have been done. I mean, since it is still not available in India, so whatever literature published is outside. And there have been studies where they have used it in head and neck and flap surgeries, the high risk reconstructive surgeries, where they have found that the post-op ICU stay and the fluid requirement as well as the use of inotropes was much lesser in this group of patients as compared to standard care. Similarly, they have used it in a very small group of patients undergoing total hip arthroplasty. So since it's a very new tool which has come up, I think more established studies need to come in to tell us more information about the mortality. For sure, we don't have anything, but yes, to reduce morbidity, there are few studies on a small group of patients.
Okay, thank you, Dr. Sangeeta.
I congratulate all the three speakers. Dr. Sangeeta Khanna, it was an excellent. We also learned new things about the HPI and the role of artificial intelligence, and Dr. Rakhi Maiwal about the lung parameters in the critical care management, and Dr. Shweta Singh, advanced hemodynamic monitoring in high-risk non-cardiac surgery. It's open for house, and if there are any comments or questions, they are most welcome. I'll request Dr. Chabra to unmute yourself, sir. Dr. Chabra, sir, please unmute yourself.
As for the artificial intelligence concern, I think we as anesthesiologists has to know this because this is a new topic and a lot of things has been coming up on it also. It's very easy if we know this artificial intelligence and machine learning, one can predict the hypotension in a particular case 5 minutes earlier or even 10 minutes earlier. Then one can react promptly and avoid the complication of the hypotension also. I think this new method which is coming up also, one has to be more relevant, and anesthesiologists must learn this. And a lot of literature is coming up on the artificial intelligence and the machine learning also. Thank you.
Thank you, sir.
Any other comments or questions are most welcome to all the three speakers.
This question would be for Dr. Sangeeta. Where does this put us on induced hypotension? For surgeries where we willingly used to induce hypotension, does this change our strategy to any extent or no?
No, I think induced hypotension is a conscious thing that we are all using in, maybe our ENT patients and all that. But there again, there is one thing which we need to know is that we should not go by what the surgeon wants us to do. I think we need to decide for ourselves as to what is that level of hypotension we can think is going to be safe for that patient. At times we just do it because the surgeon wants to see that number on the screen, that he says nahi mere ko to BP na 80 se niche hi chahiye. Most of the times I've seen that, but so I think we have to use induced hypotension in quite a few of our patients, but it cannot be guided by the number that the surgeon wants to see. But I think we need to decide what is going to be safe for.
Any other comment or question?
Right. So if there are no further questions, I think you have had an academic feast that has been unparalleled. The first monitoring, that is the blood pressure that started out way long ago, has again been re-examined, thrashed about, and we've been told that we still don't monitor the blood pressure closely enough. I thank all the speakers, and I thank the ISA Haryana branch, who has organized such a wonderful series of webinars, which I think would have benefited a lot of people. I would now like to invite Dr. Sunil Sethi, our president, if he can share some of his views and what are his further plans for the development for the ISA Haryana. Dr. Sunil Sethi, please.
I think he was just here and now he is logged in by the time he joins. I must congratulate Gurugram branch. Sunil Sethi is joining Gurugram branch and Dr. Sangeeta Khanna for taking all the efforts. Dr. Vivek Saluja and Dr. Vineet Gupta for organizing. And I can say 2 sets of webinar. This is part 1, and soon ISA Gurugram will be hosting another webinar. So this is the 3rd in series and 5th in total, and we usually do it on Sundays 5 to 6. But this time we have just slightly preponed it. And next webinar, Dr. Sethi is here, he will announce. Dr. Sethi, over to you, unmute yourself. Dr. Sethi, unmute yourself.
Yes.
Your connectivity is a bit low. Dr. Sethi? So we shall be, by the time he again have a good network, we shall be meeting on 27th December again, and the details will be shared with all of you. Over to you, Dr. Sethi. Hanji, doctor. I think there are some internet issues. So, over to you, Dr. Vivek Saluja, for concluding remarks so that we can close the meeting. And I personally thank my teachers, Professor Chavda sir, who has taught us everything. And because of his teaching, we are sitting here and discussing the scientific things with. And I also appreciate and place on record the presence of Dr. Baljeet Singh sir, past Vice President of ISA National. And Dr. Sangeeta Khanna is our past President of ISA Haryana. And all other office bearers from Faridabad, Yashvir Arya Secretary, he was here only, and Dr. Manju and Dr. Nirupma, Madam Sushila Takshar, and other delegates and friends and colleagues. So we'll continue with this academic series. I always say on a lighter side, I am going to repeat that only. Haryanvi, we feel that we have taken all the knowledge from Lord Krishna. वो एक बारी कृष्ण भगवान ने कुरुक्षेत्र के मैदान के अंदर गीता का ज्ञान दिया था, तो हमने एक बारी वो सारा ज्ञान ले लिया, तो हमें और ज्ञान की जरूरत नहीं है. तो ऐसा नहीं है. We should keep on updating ourselves about the knowledge and the recent advances. And I really appreciate, I once again really appreciate all the three speakers for a wonderful academic session. Final concluding remarks from Dr. Sunil Shetty and Dr. Vivek Saluja. डॉक्टर सलूजा आप ही कंक्लूड कर दीजिए, डॉक्टर सेठी की नेटवर्क इश्यूज हैं.
Right. Okay, so once again, I thank all the speakers and all the chairpersons. I'm really honored that Dr. Balbir Chabra was with us today. For many, he was the face of anesthesia in Haryana for a long time. And though I was not from Rohtak, but whenever he used to visit our institute,
Thank you very much, Dr. Naveen.
The amount of respect that was bestowed on him made us, all of us, respect him tremendously. And it was an honor to have him here with us today. I thank all the other speakers and I thank all the other chairpersons for helping us co-host this program. And I hope to see all of you again on the 27th. Thank you so much. I think we can conclude this meeting now.
Thank you, sir. Thank you.